Hi, everyone. Welcome to our podcast, The Animal Heartbeat. I'm Jose Novo Matos. I'm a veterinary cardiologist, and I'm here with my podcaster friend, Kieran Borgea, also a veterinary cardiologist. And we have a very special episode today, as we have our very first special guest, Professor Virginia Luis Fuentes. Virginia requires no introduction, really. If you have ever read a manuscript in veterinary cardiology or a textbook, you must have come across her work. Virginia is a professor of veterinary cardiology at the Royal Veterinary College, has published many milestone papers in our field, and most recently has chaired the very first ACVM consensus statement on the diagnosis and management of feline cardiomyopathies in cats. And we'll be talking about management of HCM in cats beyond Clopidogrel and Furosemide therapy. Welcome, Virginia.
It's a pleasure to be here.
I think, Jose, the most important part of Virginia's biography that you missed from that is that she's acted as a mentor to both of us.
How did you say that word?
So without Virginia's influence, we just wouldn't be here. This podcast wouldn't exist. So I think that's a really important thing to get in.
But I guess those were the two lows in her career. She supervised you and me.
For every up, there's a down, right?
Brilliant. So I thought we would start talking about SAM, systolic anterior motion of the mitral valve. SAM is one of the clinical features of hypertrophic cardiomyopathy in humans and cats. And SAM causes dynamic left ventricular outflow tract obstruction, which is nasty in humans. People with obstructive forms of HCM have an increased risk of heart failure and disease progression. And SAM is associated with exercise intolerance, and so is a big deal in human medicine. But what about cats? Is it SAM a bad thing in cats?
That's a really good question, because most of the studies that we have, nearly all of them have been cross-sectional studies, and those cats that have SAM are likely to have dynamic outflow tract obstruction. They're likely to have a murmur, which will get picked up maybe before they develop clinical signs. So it's very difficult to compare with cats that don't have SAM, who without a murmur, they're probably not going to be picked up very early, probably not until they develop, say, congestive heart failure. And those cats do worse than asymptomatic cats who have a murmur due to SAM. So it's a very difficult question to answer with the study data that we have available right now. What we really need, as you well know, Jose, is longitudinal studies, and your paper on CAT-SCAN 2, the study looking at cats in rehoming centres, following them over time. That's a step in the right direction, but we really need a lot more data, I think, to be able to answer that. It's very frustrating because there's so many aspects of hypertrophic cardiomyopathy that are extremely similar between humans and cats. And this is an apparent anomaly that cats with SAM tend to do better than cats that don't have SAM but have HCM. And that's different to what's often found in people.
As you're saying, the data out there is scarce. There's not a lot of data really looking at this subset of cats, and because they are difficult to define, isn't it? Even though there are out there some very well-designed studies, it's not that the studies have not had good intentions, but then they are difficult to define because SAM is labile. And it's important to stress to everyone out there that SAM will depend on how excited the cat is or the sympathetic tone. So that's a big thing in humans. In humans, 1/3 of people have SAM at rest, and another third will only develop SAM under exercise or after a Valsalva maneuver. And so in our feline population, depending on how excited the cats are, we may have more SAM or less SAM, or more obstruction and less obstruction. Do you have any trick tips? Do you try to challenge your cats when you auscultate them or when you echo them to look for latent SAM, or to try to provoke a maximal gradient? Is that something you generally do during your echo exam?
It is, but it often isn't necessary, because cats that are coming into a vet clinic to start with are already maxed out with stress. So it would be like if echocardiography was done by dentists, I suppose people might be more likely to have dynamic outflow tract obstruction if they had a tendency towards it. Certainly we'll see or hear labile murmurs, and one thing you can do to increase the intensity, my favorite, is probably picking a cat up and walking towards a tap that's turned on. That usually gets their attention. They'll look at the water running, and you may be able to get some good auscultation to pick up a murmur that's variable. I guess the opposite's true. If you've got excellent nurse restrainers who are good cat whisperers, the murmur can go away, and then you can hear it come back again if there's a loud noise. During echo, it's a bit more difficult. There's a couple of things you can do. We used to get somebody to bark, do an impression of a terrier at the cat, and that would often, again, get their attention and perhaps increase the heart rate a little bit. The other thing
is just as effective.
It is, and sometimes we do both, not necessarily simultaneously. And the other thing that works pretty well is giving treats. You can get instead of stressing them, you're causing excitement with something like liquid-based treats, and that can be enough to provoke a dynamic outflow tract obstruction. So those are probably my favored methods. A lot of cats are already stressed, and they already have dynamic outflow tract obstruction. The other one is turning on the sound on the spectral Doppler. That can act as a positive feedback loop to make the dynamic obstruction higher and higher and higher.
I guess my question is, if we don't have SAM present when they're just in the vets having sort of moderate stress, how important is it? Do you have criteria for when you think about the need to treat? Do we need to treat SAM in cats with cardiomyopathy?
Oh God, that's a really difficult question, isn't it?
It's the tough one today, isn't it?
Yeah, it really is, because if you start with, well, what would you consider severe SAM?
Right.
Already we can extrapolate from people, but knowing that many cats have dynamic obstruction, or it comes and goes, how severe does it have to be? Does it have to be present all the time? Does it have to be over a particular threshold, like 30 millimeters of mercury, often used in people? It's very, very difficult. And that was one of the things in the consensus statement that we didn't end up trying to define, because there's just no data.
It's too difficult, isn't it? It ends up being opinions and nothing more. It's interesting because when we think about, for example, subaortic stenosis, it's not a disease I think we define particularly well in terms of severity, because that's all extrapolated from pressure gradient. But obviously 30 millimeters of mercury with subaortic stenosis wouldn't even feature as being a concern. I'm not even sure we'd call it stenotic. But then we're saying that in humans, that's classified as clinically meaningful with systolic anterior motion. So it's not like for like, is it? We've got very different pathophysiologies going on and very different considerations.
Can I just stress that that's a really, really interesting comparison, Kieran. The main drive for hypertrophy with subaortic stenosis is the severity of obstruction. And so a 30 millimeters of mercury gradient of 50 is a mild obstruction, so would cause mild LVH. Here we are talking about a disease that is associated with severe left ventricular hypertrophy. And then on top of that left ventricular hypertrophy, we have an obstructive lesion. So we have systolic anterior motion. This will increase oxygen demand a lot. This will prone these cats, humans, for myocardial ischemia. And so the gradient per se, I agree, doesn't look very severe. But then if we add that gradient to a thick, diseased left ventricle myocardium that is already operating at a high oxygen demand, I think that's why any gradient is relevant in humans, because it will increase oxygen demand.
But it's relevant in people because they can work out what's clinically meaningful because of patient symptoms. And our difficulty is that this classic symptoms experienced by human patients with dynamic obstruction is breathlessness with exertion and chest pain. And both of those are pretty difficult to identify in cats. How do you know when a cat has chest pain?
Do you think you've seen them?
Yes, there's particular cases where a cat might not collapse, but might just stop, might be in sternal recumbency, or might even be a lateral recumbency, and they look anxious and they might be a little bit tachypnic. They look like they're not unconscious, but they're not fully there. We've seen cases where that corresponds with ST segment elevation on an ECG that corresponds with myocardial ischemia, but it's difficult to prove. We have troponin I as a biomarker that's likely to increase with myocardial ischemia. But the difficulty is, we're probably underestimating the impact on cats that are affected.
Yeah, absolutely.
We don't even know what happens to those cats over time. If you follow them over 10 years, do they still continue to have dynamic obstruction, or do they progress into a variation on an HCM phenotype?
So in humans who are talking about clinical signs, so tightness in the chest, angina pectoris, so chest pain, exertional fatigue, obviously they would reach for beta blockade, and they'd think about treating with a more selective beta blocker like atenolol. Do you have criteria when to use beta blockers in cats, and do you have a preference on beta blocker use in these sort of patients?
There still hasn't been very much data on use of beta blockers in terms of randomized clinical trials. The data that we do have suggests it doesn't have much effect. Now, we have to interpret that in the context of the studies that we have, and of the studies we have, none of them have been without flaws. In the NC State, North Carolina study, they had a good number of cats. It was randomized very well. They had a control group. Yeah. They measured activity levels, owner perception of quality of life, but nothing really changed very much, except the heart rate was a bit lower in the treated cats. But there weren't that many cats with dynamic obstruction. And they didn't have very severe obstruction. So it might have been quite difficult to detect a difference with that patient population.
I think the big thing with that study that was amazing, well, not amazing actually as a cat owner, but I thought was a fascinating finding, was they used the accelerometers and the CCTV to look at the cats and to see what their movement was like. And the cats were 100% stationary for 19 hours a day. And I just think that's a wonderful finding from a study, one of those sort of inadvertent behavioral traits that I think we all suspect, but it was really interesting to quantify.
Sometimes I get picky when people say, oh, there's no evidence to use atenolol in cats. And I think there are 2 points here. One is, I think we have not proved, no one has proven that SAM is bad. So you could say, why would you treat if no study has shown that SAM is a negative prognostic factor? But as you were saying, Virginia, the studies were well designed, and the investigators try really hard. But then if we look at the data, either most of them, there is a very few group or number of cats with severe obstruction, or they were asymptomatic, like the North Carolina study, as you were saying, very well designed and so on, but there was no difference in quality of life or exercise parameters between normal and affected cats at baseline. And it was like something like 80% of cat owners classify their quality of life as excellent. So there is no room really for improvement. Because one of the best studies really out there was your study with Carsten Schober and John Bonaguro on 5-year survival. That's a long study. But then a lot of cats were lost to follow-up, was open labeled.
It wasn't randomized, exactly.
Exactly. So indeed, the data out there is not strong enough. As Kieran was asking, if you could give us 3-4 guidelines, or when do you treat a cat? So if you echo a cat today in your clinic, and the cat has a gradient of 50 or 60 millimeters of mercury, there's SAM. When would you treat this cat? What are your criteria to treat the cat with atenolol?
Yeah, I've been trying to sideline that question, haven't I, since you started asking it. I think there's several factors to take into account. One is that the owner has to be up for it, because taking on medication, daily medication, potentially for life, in a cat that it ends up hiding under the bed every time you appear with a pill bottle, it's not worth it.
It's a big deal, isn't it?
Yeah, it really is a big deal. We've been looking at troponins before and after starting on atenolol, and I think Etienne Cote presented some data some years ago that suggested that atenolol might lower troponin that's probably our best marker of ischemia in cats. And we found that so far, the majority of cats who have elevated troponins to start with, it goes down if you start them on a beta blocker. If they had elevated troponin that came down with a month of atenolol, then I would be tempted to continue with it. If they have left atrial enlargement or any systolic dysfunction, I wouldn't touch atenolol with a barge pole. So those cats should not get it. I think my bar is quite high to using it, but I'm probably using atenolol more than I was 5 years ago. Having said that, if you look at the human studies on use of atenolol in obstructive HCM, we've actually got more studies in veterinary, in feline HCM than there are in human HCM. And a fairly recent, well-designed study of metoprolol in people with HCM found some mild benefits, but there wasn't a decrease in NT-proBNP, there wasn't any reverse remodeling, but it was a fairly short-term study. It looks as though it could get edged out by the new myosin inhibitor class of drugs.
That's a very cool point, because I think when we read the veterinary studies, we may believe, oh, the data out there in humans will say that beta blockers are great. But as you were saying, I don't think there has been any study showing a benefit in survival. There is an effect on clinical signs, and then they of course tailor the drug to reduce signs associated with SAM, and then they would add different drugs and so on. These are pyramid, calcium channel blockers to try to reduce the clinical signs, and they may eventually send people for septal reduction therapies. But
and there is evidence for that in terms of mortality, for sure.
Exactly.
And hospitalization visits.
Exactly. We ask very carefully our clients for any clinical signs during exercise. And it's surprising how many people would say, my cat is fine, there is no symptoms. And then if you ask, as you were saying, if they suddenly stop exercising, if they crunch when they stop exercising, if then they are in lateral recumbency after playing with a laser, or playing really hard with their cats, many people say that indeed they suddenly stop exercising, and we use that a lot also on top of the troponin I and the gradient, as you were saying, to decide which cats we will treat. So those are indeed very, very good points.
It's still got to be careful though with these overweight indoor cats that are sleeping for 19 hours a day. Yeah, they will sometimes overdo it with playing, and some of them will open mouth breathe with exertion. You can't find any structural abnormalities on echo at all, but those are exactly the signs that you'll also get in cats that have elevated troponins and do have dynamic outflow tract obstruction.
It's really hard, isn't it? It's really hard, because I've definitely seen those, especially young cats, where they get open mouth breathing after play. Yeah. And they've got what I think is a flow murmur, maybe some dynamic right ventricular outflow tract obstruction or whatever, but no SAM, no hypertrophy, no real gradient to speak of. So I just think it's a behavioral trait, or it's a lack of fitness or something like that. And they seem to grow out of it. But then you've got the ones that you see and they have got SAM, and you don't know how important it is or how well you've provoked it or what's going to happen. So I find them really, really challenging. One other criteria that I think of is, it's more common in older cats, I guess. I've seen a couple of cats with quite marked gradients and the presence of ventricular arrhythmias. And I worry there that the pressure overload may be contributing to the arrhythmia, or it's a marker of ischemia. So I guess that's another trigger for me is to think about.
Yeah, that's a good point. The atenolol has got the theoretical benefit of helping reduce catecholamine-induced arrhythmias. One thing that I think would help us with study design is deliberately separating out the cats we believe are obstructive versus those that are non-obstructive. And that's one thing in human studies, they do tend to treat them as separate populations. And they seem to be harder to recruit, paradoxically, than cats that don't have any dynamic obstruction. We need to try and have the correct target population represented in the studies that we do, and that seems to have been difficult to date.
I think June's data, when he was at the RVC with you on biomarkers on cat with SAM, I think is a really neat, we talked about that study before, is a really neat study. If biomarkers will reflect the amount of flow stress, myocardial damage over time, give us what has been happening to the myocardium, hopefully in the last few weeks to months.
Some of the newer classes of drugs for HCM in people, they're using a reduction in biomarkers as a way to assess efficacy, both NT-proBNP and troponins. So although we might not tend to use it long-term clinically, you were discussing that, I think, in the last talk, it's more convincing than quite a lot of other endpoints that we could use if there's a substantial reduction in biomarkers.
And I think that's an interesting way to use biomarkers, because in the past we've talked about using them as diagnostic tools or sort of monitoring for when to intervene, when to echo, but actually to look at them as an endpoint for treatment is interesting. And I think that, there's data out there looking at a reduction in NT-proBNP during hospitalization and prognosis, and that's super interesting. But to actually trial treat, and you take a baseline troponin or NT-proBNP and then repeat that 3-4 weeks later and see what's changed. And then anything that hasn't changed, well, those are the patients where, we'll let you off the daily medication in the absence of signs. But you guys, where we can see there's some changes on, on the biomarkers, actually, it's a reason to continue. And I think that's a neat idea. I like that.
That's been our approach. In those cats, we measure, so stage B1, B2 cats with SAM, whatever the SAM is showing us on echo, we measure biomarkers. And then if they are increased, and by increase, I mean any increase on troponin I or any BNP increase above 100, we start atenolol, and we measure again biomarkers at 4 weeks and 6 months. And then based on that, we decide what to do. I wanted to ask, so this is, of course, there's no data out there, but it's something that I've had different opinions from different cardiologists. I'd love to have your opinion on this. You have a cat on atenolol, stage B1, B2, and then after 6 months, let's say, there is a clear left atrial enlargement on that cat. Do you get nervous? Are you worried with these cats? Do you decrease atenolol? Do you stop atenolol? What's your approach when the left atrium starts to enlarge in a cat on atenolol?
That's another difficult question. I think there are some cats that if you wean them off atenolol, they still don't have dynamic obstruction. They used to have it when you started. The atenolol got rid of it initially, and now it's not the atenolol that's stopping them from having obstruction, because you can take it away and they still don't have obstruction. So those cats, I'm comfortable weaning them off. If they regain dynamic obstruction, I'd probably keep them on atenolol, but maybe a lower dose, and just see what happens. But we don't know. We don't know. And I think that's another factor that makes HCM quite difficult to deal with. We have change in phenotypes over time. And I think the dynamic obstruction cases predominantly tend to be in stage B. They're more likely to be asymptomatic. There's a lot of cats who don't have a murmur, are non-obstructive, and have signs of congestive failure, or may present with arterial thromboembolism. And it may be that we should be thinking about atenolol in the earlier stages, and then in the later stages, we should be trying to get them off atenolol, and atenolol doesn't really have an important role to play. And I think that's also important with some of the newer classes of drugs, the myosin inhibitors. It may be particularly helpful early on, but there are still some questions about later stages of disease associated with systolic dysfunction. Less common in people. I think we see a lot more in cats than with systolic dysfunction and HCM than is usually seen in people.
It's the right word, really, for us to talk about the next drug, systolic dysfunction. Pimobendan in cats, really amazing randomized clinical trials in dogs, very clear effect. Pimobendan in cats, I think there are 2 important studies, a retrospective study that showed very positive effect of pimobendan in cats, but was retrospective, always difficult to analyze those retrospective studies. And then your study with Carsten Schober, multi-center, very large study, many centers across Europe and the US, where randomized clinical trial, placebo control study of the use of pimobendan in stage C cats. So HCM with the first event of congestive heart failure.
The NC State study, retrospective study, was very carefully designed for a retrospective study and really looked very promising, like pimobendan was going to be a helpful addition to the drugs we have available. The randomized multi-center placebo-controlled study specifically set out to try and include a reasonable number of cats with obstructive HCM, because they'd mostly either been excluded or were rare amongst retrospective studies, because people tended not to use pimobendan with cats with dynamic outflow tract obstruction because of the fear that it would worsen the degree of dynamic obstruction quite reasonably. The randomized multi-center study had very interesting results. It was a 6-month study, and there was a combined endpoint of whether they could reach the end of the 6 months without an increase in furosemide dose, without death of any kind, looking specifically to see changes over a 6-month period, which was reasonable for a population of cats that had recent onset congestive heart failure. The overall results showed no difference in the proportion of cats that reached 6 months without a change in furosemide dose or anything else bad happening. But if you separated them out into obstructive cats and non-obstructive cats, there appeared to be different trends working. So it looked fairly convincing that cats with dynamic outflow tract obstruction had probably worse survival than the cats that were on placebo. So obstructive cats did not appear to do well with pimobendan. And this was despite there being a test dose at enrollment to see if they would have an increase in their pressure gradient across the left ventricular outflow tract. And if they did, they were excluded. So there were some cats that were excluded. If you included those cats or excluded them, there was still this effect that cats with dynamic outflow tract obstruction didn't do as well with pimobendan. And then the non-obstructive cats, although it wasn't significant, there looked like there was a trend on the Kaplan-Meier curves for those cats to do better if they were on pimobendan. It almost looks as though young cats with dynamic outflow tract obstruction, if you're going to treat, think about a beta blocker based on what we know at the moment. For cats that have congestive signs and are non-obstructive, pimobendan may have a role to play. At that point, it's difficult to know. It's easy when they've got more of an end-stage HCM where there's systolic dysfunction of the left ventricle. Much harder to make that decision, I think, if you have severe hypertrophy and systolic cavity obliteration and a big left atrium and congestive signs. In those cats, I don't tend to use it, but I do use it if there's any question of systolic dysfunction. I don't use it in cats with dynamic outflow tract obstruction. And there have been a few studies since then specifically looking at the obstructive cats, giving a dose showing they don't get hypotensive, they don't have acute complications, but that's not the issue. The issue is what happens if they're chronically treated with pimobendan. Could that be harmful?
And that's very different to those shorter term studies, isn't it? It's completely different to a sort of same day or same week even study. Do you factor in left atrial function to your decision making about pimobendan?
I think in the short answer is no.
Right.
I think most cats who've developed congestive failure probably will have some degree of left atrial dysfunction. I think if they have end-systolic cavity obliteration and severe hypertrophy, then I'm still not sure I want to be adding in pimobendan at that stage. Some people talk about pleural effusions, and that being a situation where they may respond better if you add in pimobendan. So that might be a situation where I would. What do you two do?
I like the idea of thinking about left atrial function and pimobendan, but actually it doesn't play into my decision making at the moment. I think the way that I assess them is I use left atrial fractional shortening as a prognostic indicator and as a decision maker for instigating clopidogrel, if they're kind of a stage B1, B2, where's the line there, I will use left atrial fractional shortening to make my decision. In terms of if they've had congestive signs and they're obstructed, I won't. I mean, I don't think we see that very often in terms of very bad obstruction.
No.
But I think in those cases, if I see that, then I think I would consider the obstruction more important than the left atrial dysfunction, or the reduced left atrial fractional shortening, I should say. If they have no left ventricular outflow tract obstruction, then I will treat with pimobendan if they've had congestive signs. So I think the left atrial fractional shortening is part of my prognostic picture. I don't think it factors into decision making for me about pimobendan.
I'm a bit skeptical or maybe picky about pimobendan on HCM. And I think this will then breach well with discussion on the new drugs available in human medicine. And if we believe that HCM in cats behaves or is the same disease as in humans, mice, the disease is characterized by a hypercontractility state. So these are mutations that cause a gain of function. So there is an increased amount of cross breaches, myosin and actin cross breaches. So the ventricle is in a hypercontractile state. And that, in fact, is probably what drives then all the hypertrophy and so on. So we are talking about a disease that is characterized by hypercontractility, at least in the beginning. I don't think then would make sense then to give a positive inotrope. Certainly, then one can argue how much fibrosis we have in this myocardium and so on, and maybe there is already some degree of systolic dysfunction when they develop congestive heart failure. But I think it's still a disease characterized by diastolic dysfunction when we see initially these cases. And so I would only generally give pimobendan in cases that are refractory to heart failure treatment. If you want stage D, I would generally start if I have a cat that becomes azotemic, with increased dose of furosemide. So more a second line treatment, if you want. That's when I give pimobendan. I like very much the idea on left atrial systolic function, because that will be brilliant. So we need a good booster function, left atrial function, to squeeze the blood into that thick, stiff left ventricle. So if pimobendan will have a good left action on left atrial systolic function, will be absolutely brilliant, absolutely brilliant. But again, there's not much data out there, but the data, there are maybe two well-designed good studies, one from Ohio and one from Bologna, on assessing the effect of pimobendan on left atrial systolic function. But the effect was mild, and they were either normal cats or stage B1 cats. So they were not the population of cats that we want to use pimobendan on. So cats with left atrial enlargement and so on. And there is no data at all to see if pimobendan could, for example, reduce the risk of ATE. That would be very neat. So I think there is not enough data out there, but I like the argument that pimobendan could improve left atrial systolic function, but I don't think we know if it does at all. I'm a bit defensive, and this is not my first line drug in CHF cats.
I think one of the interesting things that people talk about pimobendan is a positive lusitropic effect. And I know there's some data from humans. I think there's a study in dogs, an experimental study in dogs, not a clinical trial. I wonder if that would affect anything in HCM. I suppose we have to go back to the data. The data suggests that if they're obstructed, they do less well. And that's the most important study, surely.
Again, nothing against pimobendan at all. But then we are talking about a disease that also in mice models and in humans, and well, even in also dating cats, has shown that there are changes on the calcium kinetics and calcium dynamics, with mutations increasing calcium sensitivity and so on. And then we are giving a drug that is a calcium sensitizer. I don't see a reason, theoretical reason, to give pimobendan in cats with HCM.
I think if we look at another drug in the same class as pimobendan, another calcium sensitizer, levosimendan, that's not got good lusitropic properties, and some of that is the phosphodiesterase inhibition that pimobendan has, rather than the calcium sensitizing effects. So it's possible it might have some effects improving relaxation in some settings, but I don't think that's one of its main properties. I think survival and outcome data are really important with a drug that's as complicated as pimabendin and a disease that's as difficult to approach as HCM. And for now, yes, like you, Jose, I'm cautious about using pimabendin in cats. Maybe we use it a little bit like we've used dobutamine in the past, where you've got an acute crisis and it may get you out of trouble in the short term, but I'm much less likely to use it as for chronic oral administration.
And it's interesting because a few years ago, I think, I don't know, 5-6 years ago, I was much more liberal with my use of pimabendin in cats based on retrospective data. And this is a great example of why retrospective studies are hypothesis generating, not evidence generating. And obviously this is a whole wider conversation, isn't it, about the level of evidence in veterinary medicine and for what we do. But I think in cardiology, we're privileged to have an area where people are actively researching and trying to find an evidence base for what we're doing. And I think also people are quite responsive to data. So when, you know, the SHOBA prospective randomized trial was published, it did change what people did. It certainly changed what many cardiologists I know did with pimabendin in cats. Thinking about the research base is a huge, fascinating area that you've alluded to in human cardiology, which is the myosin inhibitors. Tell us a little bit about that. Do you think there's a future for that in feline cardiology?
So it is an extremely exciting area, and the basis, looking at it, it does exactly the opposite of what pimabendin does. It's a myosin inhibitor, and it has negative inotropic effects, and that can be helpful, just as we thought beta blockers would be helpful for reducing symptoms or chest pain, reducing myocardial oxygen consumption. But it's looking like it has a range of other positive effects. So they have studies in people now that show not only can it relieve symptoms associated with dynamic outflow tract obstruction, but it can also lead to reverse remodeling. So developing more normal myocardium and improving function, including improving relaxation. So it's looking like it's ticking a lot of boxes.
This feels like what we're looking for, doesn't it?
Exactly.
Or what we've been looking for, yeah.
And it was discovered partly by a drive to have targeted therapy for cardiomyopathies. And initially there was concern it might only be effective for particular sarcomere mutations, but it may have broader applications than just that. So it's mostly been studied in people with dynamic outflow tract obstruction, but it's now starting to be looked at in non-obstructive HCM as well. There are some preliminary studies in cats. So Josh Stone's colony at Davis, they have shown that anesthetized cats with dynamic outflow tract obstruction responded to mavacamten is now the name of the first in class drug of myosin inhibitors. It's been used in mice as well, and a more recent study looked at dosing in cats with HCM, but again, these are cats with low gradients to start with, not severe dynamic outflow tract obstruction. So we are really hoping this is either mavacamten or other related myosin inhibitors may become available to have studies in cats with naturally occurring HCM. Very exciting.
Super exciting. I guess that the worry in the short term is there's a rapid route to market for humans, and they're going to be very expensive, aren't they, when they're first released on the human market? And there's always a challenge there. I mean, I remember when sildenafil was super expensive, and only the people who had the least financial restriction could treat pulmonary hypertension with sildenafil. And now that the landscape's very different, certainly in the UK, I feel like we might be headed that way with these molecules, with mavacamten and that family. But hopefully down the line, there's a future for it for us as veterinary cardiologists.
The cost here will be a major issue. And that's interestingly a very active discussion even in the human field. Because as we were discussing before, people with severe obstruction that do not respond to medical treatment have an indication for surgery, septal reduction therapies, which are either septal alcohol ablation or myectomies. And that's a big field, huge field in humans, and with very, very good results. If you follow some forums in human cardiology between surgeons and medical cardiologists, there's a big discussion because surgery will still be cheaper than the treating patients with mavacamten or aficamten. So the cost is huge. And also people question a lot, will it ever be available for less favorable countries? Because it will be so expensive. So that's my concern, that it will take many years to reach the veterinary market. Just for our listeners that are less familiar with these drugs are drugs, as Virginia said, and Kieran, are incredibly smart drugs. We are not working at the receptor level anymore. So beta blockers, calcium channel blockers, all these drugs act at the receptor level. These are small molecules that act at the sarcomere, and that makes them incredibly clever. And so they will inhibit myosin heads, and by doing that will decrease the amount of myosin-actin cross bridges. So we are working at the sarcomere level. And there's also very exciting drugs for dilated cardiomyopathy, where they will enhance sarcomeric function. And so it's indeed a really exciting field that now we are managing or changing the sarcomere, directly acting at the sarcomere and not at the receptor level. That's indeed very cool.
They're still probably going to be cheaper than gene editing, which is going to be the next level.
That'll be the next generation.
Being looked at, they're already looking at that, a big drive, because we'll need to know the mutations and then get the fix to edit them. But
that's a big limiting factor right now, is the absence of understanding of what's actually happening in cats with the genetic mutations. We have 3, and the odd family here and there. So there's definitely some work to do there. But I love the idea of hopping on that next generation technology. And I guess there's an opportunity for us in terms of research there. If we can phenotype our cases very well, our cats that come to the clinic with cardiomyopathy, and then we can genotype them and they can be sequenced. If we can identify the right mutations there, could cats act as a naturally occurring model for the human disease? Would that be a way in for us to try and contribute to that generation of research, but also have opportunities for our patients as well?
Maybe we could briefly discuss about anticoagulation, even though our topic is beyond clopidogrel and furosemide treatment. It would be great to have your input, Virginia, on how do you anticoagulate your patients? Which antiplatelet treatments do you use, or antithrombotics? What's your first choice and maybe second choice when you're very worried about clots?
Are you talking about preventative, secondary prevention?
Preventive, yes.
So we go with clopidogrel as standard. We don't even necessarily, if they come in with, say, congestive failure, and we think they're high risk for developing ATE in the future, our emphasis is still on the diuretic to begin with. We don't necessarily send the cat home after being admitted with 2 drugs, one of which is quite difficult to administer because it's not easy to administer. If it's your first time trying to give a pill to your cat, you may be horrified at how difficult it can be. And clopidogrel, if they end up making the cat upset, salivating, running around the house, retching, they may not be
uncommon, is it?
No, it's not. They may be unable to get the diuretic in, which is what might keep the cat alive over the next 2 weeks. So we might get them to start the following week once they've successfully managed to give the furosemide over the first week or so. And that would be our standard drug. When you start it, we give a loading dose to acute ATEs, but we don't necessarily give a loading dose to a cat that has come in for congestive failure or something else, and we think they're at risk. That those cats, we just start with this standard 18.75 milligrams.
Do you have a time when you've got a cat who's on clopidogrel where you might consider either changing or augmenting your antiplatelet or anticoagulant regime?
So I guess yes is the answer. If you've got a cat that has had a previous ATE event or a cat that you believe is very high risk, then we may add in a second antithrombotic. That used to be aspirin, and now the question is whether we should add rivaroxaban to clopidogrel. I think the risk of bleeding is probably going to be greater with clopidogrel and rivaroxaban. There's a few situations in people where the combination of aspirin and clopidogrel has been quite successful, as opposed to just clopidogrel alone. But again, we don't have the studies. It's, we've been lucky to have the Fat Cat study and the Super Cat study looking at clopidogrel versus aspirin and then clopidogrel versus rivaroxaban. But we don't have any studies looking at the combination. And I think at the very least, it would be good to have safety studies looking at the incidence of bleeding problems with combinations, because all of it is just anecdotal evidence and personal experience.
I'm going to share my N=1 anecdote now.
Thank you.
Which actually was a cat who was on clopidogrel and aspirin. So it wasn't what I would consider particularly heavy-handed regime. The doses were standard doses, although I tend to dose aspirin every other day rather than every third day. I guess that may not be standard for some people. This cat needed some sedation, and I gave an IM injection of butorphanol, and it got a big hematoma. I was absolutely horrified because I felt it happening under my fingers as I was coming away from the thing, which was a real shocker. I mean, the cat was fine, but it certainly made me think a little bit about those cases, and actually, do I need to add a second strand of antiplatelet drug or anticoagulant? And if so, how palpable is that risk of bleeding or whatever? So it definitely made me think a little bit. It's not that I don't do it now, but it's just that it sticks with you, doesn't it? Those sorts of cases.
I think for cats that are outdoor cats, I'm a little bit more cautious. Otherwise, it's partly down to how much risk there is of the ATE, which is worse in most cases.
Exactly. Weighing the pros and cons and the risk of ATE, which is absolutely horrible, dreadful, and having a careful conversation with a client about risk of bleeding. I generally tend to be more aggressive, I would say, and we more frequently now add rivaroxaban. So if I have a cat with smoke, close to zero LA systolic function, gigantic left atrium, sometimes we start from the beginning rivaroxaban and clopidogrel with no data. I'm not saying that this is better than one or the other. We don't know, but consider that in humans, combination of drugs have been shown to be more efficient. We tend to do that. There's a Super Cat study, right, going on. Do you guys know anything about it?
They finished enrollment for Super Cat. I don't think any results have been presented yet, as far as I'm aware.
They haven't been presented, but the study is closed, not just stopped enrollment. I think it's important to consider if there's going to be elective surgery of a cat that's on an antithrombotic, to consider weaning them off that 5 days, at least 5 days before surgery. It probably depends on the surgery.
I mean, it's not uncommon for these cats to need dental work or whatever, is it? Which is, it is elective. Obviously, it's important, but it's elective. So you can plan that a little bit around the clopidogrel or whatever.
Yeah.
Maybe
we could now talk a bit about antiarrhythmics. Again, another field full of data and RCTs and so on, feline cardiology. But it would be great to have your input on that, Virginia, and your experience. Could you tell us would you approach, or how do you treat SVT in a cat, and then also ventricular arrhythmias in a cat? What's your drug? What's your first line treatment?
We're in the Wild West now, with very little in the way of any evidence. So SVTs, the difficulty is often in diagnosing them in cats because they can be intermittent, and unless they come in weak and collapsed with extreme tachyarrhythmias, then that at least allows you to make an ECG diagnosis, and you can start straight away. So for an SVT where we're happy it's a supraventricular tachycardia, diltiazem is usually our first choice. It's probably not going to cause too much harm if it doesn't work, and it often does work. For the cats where you suspect it, but you haven't actually caught them, maybe somebody else has documented an extremely high heart rate, and the cat has had episodes of being quiet or weak or collapsed, but looks fine when it comes into you and it's got a normal rhythm. Those are more challenging. Often at home, they may have had episodes of tachypnea, and you don't know if they've developed flash pulmonary edema due to something, or whether they're tachypnic because of a sensation of palpitations associated with supraventricular tachycardia. We've had a lot of success with owners of cats like this using the Cardia Mobile Alive Core device, because some owners can get quite good at putting the ECG plate of the Alive Core device on the cat's chest, particularly if it's already been clipped from a previous echo, and recording an ECG onto their smartphone that they can email to us. And that can be incredibly helpful for documenting intermittent episodes. And we've even had owners who have been able to recognize the difference between an SVT that requires, okay, give an extra of the SVT tablet, or whether it's pulmonary edema and they have to give an extra furosemide tablet.
That's great.
Which is brilliant, because it saves the cat having to come in when it's already stressed and weak. If you've got the right owner, that can work really well. For some of those cats, if diltiazem doesn't work, we'll use atenolol. But obviously you don't want owners giving beta blockers willy-nilly when they might be having flash pulmonary edema. So the Alive Core device has been quite helpful for that in our experience. Do you two use it? Get owners to use it for intermittent arrhythmias?
No, I've never had any success. We used to have a device in a clinic where I was based previously, and occasionally would sort of loan it to people, and at that point, I don't know what the status is now, but at that point the app was free, so people would download the app and then use the sort of Bluetooth device. We had a couple of people get a little bit stressed. We didn't get particularly rewarding results from it. So to be honest with you, I gave up. But that's probably more of a comment on me than it is on the device.
I think a little bit of wet the skin can help. And at least with an intermittent tachyarrhythmia, you've got long enough to fiddle about, get the device out, get the skin wet, get it stuck on the chest, and or hold it on the chest, and the cat's going to keep still enough because it's thinking about its palpitations.
Yes, yeah, I think we the context in which I used it was slightly different. Actually, we were looking at monitoring atrial fibrillation rates in dogs and trying to look at that at defined points in the day, and we just found the results were not very useful. But again, completely different situation. They were often bigger dogs, not smaller cats, and the contact may have been very different. It's really interesting hearing what you say, and I think it's definitely making me think about revisiting that.
We also use it, and as you were saying, Kieran, we bought one device, and we loaned to some clients that are not ready to purchase the device, although it costs like £99, I believe. And people think, I think most owners, when you tell them that, they are very excited to check their own heart rate and the cat's heart rate. But our challenge, so we came up with a small protocol where people send us traces in the first week. When the cat is not having symptoms, just to see how good the quality is. We generally give them a bit of gel in a little pot or syringe for them to use gel, because our challenge has been really contact but also, yeah, as you were saying, Virginia, making the fur wet and so on helps. We generally clip them just to improve contact, but can be very rewarding, especially because we don't have really good alternatives out there, isn't it, for intermittent arrhythmias in cats. The Holter monitors are huge, and stuff like Reveal is a big step for most owners and cats. Have you ever used the patch, the Holter patch, where you just use that little patch that gives you one ECG lead or a Holter lead?
I haven't personally, no. Kieran?
My understanding is that those single lead ECG patches are quite large. I think, but for cats, they probably would be too big, wouldn't they? I've not tried it practically.
The idea would be a small enough device that they can wear it quite easily, somewhere they can't remove it, which I'm not sure where that would be, on top of their head.
I did a couple of times try what was reported years back now in the Journal of Veterinary Cardiology about using an implantable loop recorder, the Reveal device, on the skin, with cutting off the gel patches from some electrodes, fixing them on, and actually we got reasonable trace, but the cat had quite a big bandage on, and I thought at the time, well, maybe this is no different to a Holter. Actually, I currently use a very small Holter system. They're about the size of an egg, but the leads are still quite large and heavy. So I still think that now the system that I've got, the leads are more of a problem than the actual Holter unit. So I still don't think there's a great option for that ambulatory ECG monitoring in cats, maybe apart from the Alive Call.
How do you approach a cat that has VPCs during an echo? Because I really struggle. Because if we have a dog with dilated cardiomyopathy with VPCs, that's a clear indication for a Holter to assess the burden of the ventricular arrhythmias and decide on the need for antiarrhythmic treatment. Now, if you have a cat, while you are scanning, assessing the cat with HCM, stage B, stage C, where you see single isolated VPCs, how aggressive are you in pursuing those VPCs? Do you consider Holters, or you just monitor them?
I'm always really worried with cats that the stress of putting a Holter on them is going to end up causing them to fibrillate. So I'm pretty cautious about using Holters, and I'm fairly tolerant of seeing VPCs. If they look like they haven't got left atrial enlargement, but substantial LV hypertrophy, I'm perhaps most likely to put them on atenolol. If we see ventricular tachycardia, then I'll probably start with atenolol and may consider sotalol. It's very difficult to know, because I don't think we have enough data on the prevalence of ventricular arrhythmias, isolated VPCs in cats in the wider population.
And I think we've already mentioned the effects of catecholamines and the fact that you can have catecholamine-induced arrhythmias. And of course, if the worst part of their week is the echo that you're doing, well, are we surprised they get some arrhythmias at that point? It's such a challenge. I think this is one of the hardest parts in decision making for treatment. I think, for all our discussion about pimobendan and atenolol, I think we all have our own protocols with those drugs, and they're based on data, they're based on theory, they're based on our own experiences. With arrhythmias, I think, as you say, it is the Wild West. I really don't think anybody has a what I would consider a really solid approach to how to diagnose and assess clinical significance of these cases. A cat is not a boxer dog.
And we know that sudden death is one of the manifestations of HCM, and it gets underreported. It would be great to have a better idea of what's going on out there, and trying to, because of the size of Holters, it just makes it very difficult to gather good data.
Regarding the stress in consultation and echo, I like that, and to use in our own favor. So there's also a lot of arguments about SAM, as we were discussing before, that if SAM only happens on echo, when there are stress, are we worried? But I think that's indeed a stress test, an exercise test in comparison with humans. And even if they only exercise 10% of their day, if we, again, the risk of sudden cardiac death in humans with HCM is very high during exercise, or is increased during exercise. And so there will be, again, a moment of high adrenergic tone. So in fact, I think if there is SAM during our echo assessment, and or there are ventricular arrhythmias while the cat is in the clinic, this may also happen when the cat chases a bird or a squirrel or plays with laser. So in fact, I think that's not bad. I think that's good that we see that, because then that will be relevant, because the cat will be equally stressed, maybe 5%, 10% of their day. I wanted to ask you about sotalol. So in the past, whenever we would have ventricular arrhythmias and HCM cat, we would use atenolol. And if there is an obstruction, dynamic left ventricular tract obstruction, atenolol is still our first drug. But then if there isn't, And these are cats that the left atrium is most likely to be dilated and so on. We more frequently we use sotalol now, hoping that there is a less strong beta blocker effect. Do you use sotalol? What are your thoughts about sotalol?
Another difficult question. Yes, we do use sotalol. We're perhaps more likely to use it for cats where ventricular tachycardia has been documented, but we don't have randomized clinical trials to show whether sotalol is actually increasing the risk of sudden death in these cats. Atenolol is probably a safer choice if we're concerned that sotalol might be pro-arrhythmic. So I think that's still a work in progress. We still don't know the best approach there. Atenolol is the safest if you haven't got a big left atrium. It's probably the least likely to have pro-arrhythmic effects.
And sotalol is still a profound beta blocker, isn't it? It's not a benign drug, of course. And I think one of the difficulties that I always have with sotalol in dogs as well is the whole thing about the QT prolongation and the pro-arrhythmic effect. I've definitely seen that in a couple of dogs where I've made their ventricular arrhythmias worse by giving them sotalol. And I think on the second one, I retrospectively went back and measured the ECG and corrected the QT interval and thought, actually, I shouldn't have used sotalol in this case. So now I'm definitely more cautious in dogs about assessing QT interval before using sotalol. And cats are just a minefield because I can't characterize the arrhythmia well enough in advance. I guess unless they present in VT, and then I'll just treat them, because what's the other option? What can we do?
What I also like about sotalol, my problem with diazoxide, which is my first choice for SVTs, but is the fact that you need to give it TID, and owner compliance is always a major issue. And then if these cats will be on furosemide, clopidogrel plus diazoxide TID, I think is a big thing to ask some clients. So I would also use sotalol in some SVTs if we feel like it's too much for the client and for the cat to give a tablet TID. That's the only thing. I don't like drugs TID in general, because I think it's again already difficult to give it BID, and then TID is I think is incredibly challenging. Do
you ever use the human modified release formulations?
I was about to ask about doses and so on, but
it's not ideal. Not ideal.
I know there are listeners out there who will be thinking about the use of compounding pharmacies to get the right tablet size of the right formulation for cats. Is that something that either of you use regularly for antiarrhythmics or for anything else, in fact?
We do for clopidogrel. So where it's difficult enough dosing cats, the pharmacokinetics are going to be more of an unknown quantity.
Right.
So there's always the risk that it's not the same as using the original medication, but it's better. It might be better than not getting any medication at all.
That's always my worry. And so many colleagues that I've spoken to in the US and elsewhere in the world. So for example, Brazil, I know a few people who are active in the veterinary cardiology community in Brazil, and they use amiodarone a lot for ventricular arrhythmias in cats. And an SVT as well. It's their go-to antiarrhythmic. So they will often use compounding pharmacies to achieve the doses of amiodarone they want to use in cats. It's anecdotal, but it's an interesting idea, isn't it? It's not something I would ever reach for.
Yeah, it's definitely got a role, because it can be so difficult to get the right size medication for cats. They're not always great just crumbled up on food. Cats are too clever for that.
I think there's a huge amount we could talk about with the treatment of cardiomyopathy in cats. The traditional therapies, the diuretics, the antiarrhythmics, there's a lot of scope for discussion. But I think we're coming to the end of a reasonable time to have a podcast discussion about it. So thank you so much, Virginia, for joining us. Honestly, it's been a great pleasure and a learning curve, I think, for both of us as well, to just review some of these key points. One important key thing to think about when prescribing medication for cats is that most of it's off-license, off-label use in the UK, and therefore we've got to make sure we've got informed owner consent for using these medications. Virginia, do you have any key take-home messages from our discussion that we want to leave as the final word on treating feline cardiomyopathy beyond the standard therapy?
There's a few things, and one thing we've touched on is how difficult it can be to get medications into cats. And I think avoid the temptation to pile in lots of different medications and hope that that's going to work. The last thing we want to do is put cats off being medicated. And so only use a drug if you think there's absolutely a reason to use it. For atenolol, bear in mind that cats may have arrhythmias, they may be at risk of sudden death because of ischemic myocardial problems, but also they may be experiencing clinical signs that we can't recognize. And particularly with HCM in people that can cause chest pain, angina, that's something that's very difficult for us to recognize. And I think that's made me start to use atenolol again more frequently in cats that have severe hypertrophy, don't have left atrial enlargement, those cats that could be at risk of ischemia. A warning that would be having high troponin I concentrations, and we use that both as a sign to consider using atenolol, and also as something to recheck a month later, after a month of treatment, has the troponin gone down with therapy? And we can think about using biomarkers as a way to test efficacy. Has there been an improvement in biomarkers that suggests this drug might be helping? And then pimobendan, I would urge caution using it in cats with obstructive HCM. And we should be thinking about, is this cat obstructive? Is this cat non-obstructive? Because I think we do manage them differently. And for cats that have dynamic outflow tract obstruction, I would be very wary about using pimobendan at all. I think the cats with some left ventricular systolic dysfunction or signs of congestive failure without obstruction, those are cats that there could be a potential benefit from using pimobendan in them. So that would be the target population for giving pimobendan. Those, I think, would be some of the main ones. And of course, we all look forward to the day where we can use myosin inhibitors in cats with HCM, because that will finally be a way of actually targeting the disease rather than just treating the symptoms.
Brilliant.
Great. Thank you so much. So thanks everybody for listening to The Animal Heartbeat. It's been a pleasure to welcome Professor Virginia Luis Fuentes today. Please stay tuned for other guests in the future. And please remember to follow us on Twitter and Instagram. The handle for those is @heartbeat_pod. And remember, we'll tweet images that support the things we're talking about. We'll send links to articles. We're open to questions about future topics. And we will, of course, publicize on there our upcoming episodes and future guests. Thank you very much to Virginia and to Jose.
Thank you so much. I've had a great time chatting to you guys.
Thank you, Virginia. Bye now.